Hello everyone, myself Dr. Devendra Singh from AIMS New Delhi. In this video presentation, I will discuss the technique, tips and tricks of stapler haemorrhoidopexy. Stapler haemorrhoidopexy is a minimal invasive surgical procedure for symptomatic hemorrhoidal disease. It is known by various synonyms like minimal invasive procedure for hemorrhoids, anal facelift operation, Longos operation after its inventor, procedure for prolapsed hemorrhoids, anal prolapsing mucosectomy or circular anopexy. In this technique, a circular stapling device is used to resect the rim of mucosa and submucosa above the dentate line, which lifts the anal cushions up in the anal canal along with devascularization of hemorrhoids. And this ultimately leads to shrinkage of hemorrhoidal cushions and restores them to their normal anatomical location. Indication of stapler haemorrhoidopexy includes grade 3 and grade 2 symptomatic hemorrhoids refractory to medical management. The outcome of stapler haemorrhoidopexy is more favorable for patients with prolapse predominant symptoms and patient desirous of minimal invasive and less painful approach. Although it is associated with slightly higher recurrence rate over the conventional open or closed hemorrhoidectomy when applied to grade 4, so adequate patient selection and meticulous surgical technique is the key to success of this surgical procedure. Stapler haemorrhoidopexy should not be offered to patient with history of inflammatory bowel disease, coagulopathy, patient on blood thinners, patient with anal stenosis or active anorectal sepsis, patient with decreased anal tone, and in homosexual males. Apart from the history and clinical examination, routine blood test, colonoscopy should be done for patients more than 50 years of age to rule out any malignant condition. The patient planned for stapler haemorrhoidopexy are usually kept nil per oral for at least 6 hours and proctoclysis enema is given on the day of surgery, and the procedure can be done both in regional or general anesthesia. Patient is positioned in extended lithotomy position with thighs slightly flexed on the abdomen. A sandbag is placed beneath the buttocks and the buttocks are straightened out using leukoplast so that the anal opening gets flat. Gentle digital rectal examination and dilatation of anal canal is done to facilitate insertion of the obturator and circular anal dilator. Now let's see a complete video of this surgical technique along with various parts of the stapling device. This is per string suture anoscope with marking from 1 to 4 in centimeter. This is suture threader for pulling out suture from stapling housing. This is obturator for dilating the anal canal. This is circular anal dilator with vertical height of 3 centimeter to protect the dentate line. This is MIPS stapler with stapler housing marking from 1 to 4 centimeter. This is the red safety knob. This is the rotating knob to open or close the anvil. The proximal node part is known as the anvil. This is our indigenous anal pack prepared by wrapping roll gauze mixed with betadine and xylocaine jelly. After placing the patient in extended lithotomy position, gentle finger dilatation of anal canal is done, followed by insertion of obturator. 4 quadrant skin sutures are taken from perianal skin. To prevent proximal migration of anocutaneous junction and dentate line during insertion of obturator along with circular anal dilator. Then the pre-tied sutures are taken out through the phalanges of circular anal dilator and it is fixed to the anal canal. The vertical height of circular anal dilator is 3 centimeter and thus if it is properly fixed, it protects the dentate line. Then the purse string anoscope is inserted and purse string sutures are started at 3 o'clock using Prolene 26 mm half circle needle with a long 8-inch needle driver. After taking the bite, we lift the mucosa and submucosa to ensure that the suture is neither too deep involving the muscle layer nor too superficial involving only the mucosa. The PSA should be reinserted in each quadrant to avoid spiraling and tearing of the hemorrhoidal masses. The each entry bite is just proximal to the previous exit site. Purse string suture is the Achilles heel of this procedure. At 9 o'clock position, we prefer to place a loop of Prolene suture through the purse string to provide uniform traction. Anteriorly in females, extra care should be taken to prevent any injury to the posterior vaginal wall. and this can be checked by pervaginal examination and noting any tethering or pulling suture down. Gradually, the whole of the pursing is completed. The pursing action is checked by finger and pulling the pursing suture. Then MIPS stapler with fully open anvil is inserted through the pursing, and we get a feeling of give way when the anvil goes beyond the pursing suture. Pursing is tied over the anvil shaft, and the sutures are taken out using suture threader. Similarly, to maintain uniform traction, the pre-tied loop at 9 o'clock is also taken out of the stapler housing, and both are tied together and hold it with an artery forceps. Both sutures are pulled out and the stapler is gradually closed till it comes in the firing zone indicated by the orange indicator in green zone. At this point, we again do PV examination to check any entrapment of posterior vaginal wall, which may later present as rectovaginal fistula. At this point, whole of the stapler housing with marking 1 to 4 centimeter is inside the anal canal, ensuring that our staple line will be well above the dentate line. Then the stapler is fired in one go after opening the safety lock, and it gives a crunching sound due to the cutting of the gasket in stapler housing. The stapler is opened half to 3/4 of the circle, and with gradual sideways movement, the stapler is taken out. The adequacy of donut is checked and sent for histopathological examination. First speculum anoscope is again reinserted to ensure hemostasis. All quadrants are sequentially examined to look for any bleed. Use of laparoscopic light source makes the vision excellent. If there is any spurter, we can control it by taking figure of 8 suture using Vicryl 30. After ensuring hemostasis, anal pack is inserted, which is removed 4 hours after the surgery. Sutures are cut and the circular anal dilator is removed and a simple dressing is applied. So to conclude, hemorrhoids are a lifestyle disease, and for success of any surgical intervention, proper patient counseling is must. Train the patient not to strain and avoid constipation at any cost. Use of laparoscopic light source and long instrument makes the surgery ergonomically easy. Stapler haemorrhoidopexy is a good minimally invasive technique in selected group of patients with advantage of less pain and faster recovery. The complication rate can be substantially reduced by adequate training and proper patient selection.